We know there's been so many challenges rolling out this vaccine all over the world. Why is that?
The day the vaccine was launched, there was all this negative propaganda on the media.
It's an issue of trust. No matter how you try to let people understand the need for vaccine, if they have no trust in the people doing the campaign, you hardly penetrate them and you hardly deliver.
Parents just want their concerns to be taken seriously, and they want to be listened to, and they need specific information, not general information.
We lose 9 women to this disease every single day, round the clock, 365 days a year.
Good morning, good afternoon, wherever location you are. We're so thrilled that you're joining to listen in to this podcast that's IPVS is presenting to help us talk about HPV vaccine. I'm Linda Eckert. I'm an obstetrician gynecologist at the University of Washington in Seattle, USA, and the author of a book called Enough Because We Can Stop Cervical Cancer. And I'm delighted to be here today with my panelists. We have Bernice Hausman, who's an academic whose work examines public trust and narratives around vaccines, which she has explored in her book called Anti-Vax. We have Dr. Noreen Zafar, who's a working OBGYN in Pakistan, founder of the Girls and Women's Health Initiative, and a passionate advocate for HPV and cancer prevention. We also have Imam Rashid Abdughani, who's an imam and a professor of Islamic studies at Gombe State University in Nigeria, whose work as the dean of students has brought him into the HPV vaccination space. So today, as we get ready to kick off, I think it would be helpful to hear just a little short bit from each of us what brought us into this cervical cancer space. And for me, I had a very personal experience when I was a fourth-year medical student, and I traveled to Liberia. And I distinctly remember my second day there when I met my first patient with advanced cervical cancer. And at that time in Liberia, and still in many countries, there was nothing we could do for her. There was no treatment. There wasn't even pain medicine. And it just literally broke my heart and changed how I feel about equity in medicine and access, and led me down this path that eventually became centered on prevention of cervical cancer. Bernice, you want to tell us what led you to this table?
So I started studying vaccination controversy when I realized that colleagues of mine and friends of mine who had children that were younger than mine were nervous about vaccination. Since I studied public controversies around medical issues, I thought this would be a really interesting topic. And what I have come to believe is that a lot of vaccine hesitancy is misunderstood because it's automatically connected to ideas about misinformation, and that importantly, we really have to address the actual concerns that people have, meet them where they are, to understand why there's so much concern about vaccination today. And the concerns and issues around HPV are a little special because the vaccine itself is unique in terms of it being a cancer vaccine and oftentimes really targeting girl children. And so I think those issues are just really interesting to study to understand why parents have those kinds of concerns.
Like yourselves, my introduction with cervical cancer was in 1987 when I had just graduated. And the first patient that I lost was a young girl who left behind 3 little orphans and died very painfully in our hands. But when I went to the UK in 1992, 5 years later, I could see that CIN3 can be treated and the women and the families can have a normal living and life, and cervical cancer did not have to kill. We started this campaign, No More Cervical Cancer. But now with the vaccine, 2 decades of success, I really, really believe that cervical cancer can be eliminated. And that's how we've ended up working for it every single day.
Rashid, we're so glad you're joining this podcast. Can you tell us a bit what brought you to the cervical cancer table and your motivation for being here?
The issue of anything that has to do with vaccination in our society here, especially in Nigeria, is always a concern for all. The need for the vaccinations all through in different diseases are there. And the perception of the community about the whole issue about vaccination is also an issue of concern. In most cases, there are a kind of conflicts between the health workers and the community in terms of sensitization. So actually, this is one of the issue why I personally, as a religious scholar, picked interest. Leaving it to health provider alone will actually not solve the problem, and we may not achieve the goal expected. Thank you.
I think that we're all here because we really believe that a cancer preventing vaccine is such a rare gift. But as we know, there's been so many challenges rolling out this vaccine all over the world, actually. And why is that? That's partly what we want to talk about a bit today. We know that some issues have been with the supply, although that's getting better, of the vaccine. And the cost also has remained prohibitive, especially in a lot of countries that don't get assistance from an organization for funding, such as Gavi. But even with that funding, it still can remain out of reach. So I just want to turn to you first, Noreen. I know Pakistan just rolled out the vaccine with Gavi support, and I wondered if you could give us any insights as to some of the persistent challenges or some of the successes that you saw in Pakistan.
Well, it has been a moment that we've been really, really waiting for. And through the help with the government and Gavi, of course, we have the vaccine, and it is a phased out approach at the moment. Almost half of the country introduced the vaccine in September 2025, whereas the other two big provinces are going to follow in 2026 and 2027. In spite of the fact that the vaccine is available, there's a whole lot of factors at nearly all levels of healthcare provision and the community interaction that have been a problem, and we have had not a very smooth ride, I must say. Firstly, the biggest problem is that we now have the Gavi support, but the worry that we have is the sustainability of this campaign. Once the Gavi support withdraws, which is obviously for a finite period, we do not have anything in the policy, and the financial groups have not really thought about how we are going to obtain this vaccine after the Gavi support withdraws. Like Bernice said, HPV vaccine is a very unusual vaccine. It is not the usual run-of-the-mill vaccine that the mothers know that all babies are going to get. Girls between 9 and 14 usually do not attend for vaccines. Obviously, there are girls in the school, but a huge problem that we have is almost 1/3 of our girls are out of school. And this is different reasons across the whole country. So that is also a challenge. Then there are people migrating. Then there are natural disasters like floods that we had in August and September. And then there are man-made disasters, war and IDPs. So it's very difficult to keep track of the girls, even those who are in the schools. And then there are many schools which are not registered. So that's like an administrative set of problems. But once we trickle down, I think it's the healthcare providers, the numbers of the doctors, and then do we involve the mid-level providers? And if we do, then it has to be a very organized, standardized, evidence-based IEC material which can be shared with them so that they can pass the message on very, very clearly. So, it's a different problem at all different levels. So we need an intersectoral and intrasectoral approach, which is panoramic in its approach and which does not leave anyone behind.
Noreen, you were listing a lot of the challenges, but I know Pakistan got a lot of shots into arms of girls. What was helpful or what was successful in this campaign?
What really, really helped us was a personal human touch. It was a combination of all three places, the schools, community, and the mobile system that was used for the campaign. The first 5 days of the campaign, the numbers were like really not very good, and the refusals were climbing up. On day 5, the federal minister, Mr. Kamal, he just came online. He brought his daughter Rija along, and he got her vaccinated. And he spoke a few lines about the value of the vaccine and that this is my daughter. And they'd never been on the media, his family, and that was the first time that they were there. Right after that day, we could see the slope going up, and the refusals going down. And then the campaign was extended for another 4 days. I think that was really a classic thing that tells us that women and families are ready to listen. It really depends how we get through to them. Because prior to this, one big problem that we were having was that the day the vaccine was launched, there was all this negative propaganda on the media. We were like, what is happening? Because there was nothing there, and we had not thought about pre-bunking at all. So everywhere where we discuss these things, I believe that pre-bunking is a very important initiative that should be taken by all countries who are planning to launch the vaccine, because everybody has a mobile phone and everybody has access to social media, and doctors don't really talk so much on social media about health issues. So there are all these people who provide unclassified information, and people believe them whatever they are saying. And another thing that we experienced this time, which is unique because of HPV vaccine, is that it was not only OBGYNs, it was family physicians, it was the dentists, it was the pediatricians, it was the EPI, expanded program of immunization, it was the FDI, CSOs, and above all, the mid-level providers, who were all involved in this chain of continuity. Any break along the chain anywhere resulted in problems.
So, Bernice, as a researcher, what have you found about what you're hearing from Rashid and Noreen, and how does that cross with narratives around vaccines that you've learned about in general or specifically with the HPV vaccine?
So one of the things that's really important to understand is that vaccine beliefs are really embedded in local cultures. And so it's going to be really different in various local cultures. Religion is very important context for understanding specifically HPV vaccination acceptance, because of the fact that the human papillomavirus infection is generally sexually transmitted. And so local cultures and local religious beliefs around sexual behavior are really, really important. So the vaccine is challenged by those things because it links parents to these ideas about especially their girls' sexuality. And in most societies, girls' sexuality is highly surveilled and controlled by families. So the HPV vaccine kind of raises anxieties about girls' sexuality. It raises questions about parental domestic authority around health. It raises sort of questions about whether or not parents can trust their daughters' choices around sexual partners in ways that can be very destabilizing for parents, especially with girls that are as young as 9. Parents don't want to think about those things. Noreen alluded to these sort of like questions around damaged reproductive futures. There are these concerns about whether or not a vaccine against a sexually transmitted disease could somehow damage a child's future reproductive success. And those hover in societies in very, very different ways. In the United States, after an initial sort of religious objection from the Christian right to HPV vaccination, the discourse has actually shifted significantly towards discourses of vaccine injury. And vaccine injury is another way of expressing this concern about the possibility of damage from the vaccine. So this idea that the vaccine could be harmful and that it has the power to sort of rob girls of their reproductive futures is a very, very significant theme in the vaccine injury discourses around HPV. There's a really wonderful book by Nicole Charles, who's an anthropologist, called Suspicion, about an HPV vaccination program in Barbados. And she uses suspicion as this sort of metaphor for concerns about vaccines and other biotechnologies, like biometric screening for immigration or travel, and how people sort of see all of these technologies kind of circulating together in a governance system that has concerns around girls' sexuality and their place in the culture. So I think that we have to see vaccine concerns as linked to the local cultural context and then other concerns that permeate there.
Rashid, in Nigeria, how, and as an imam and a religious leader yourself, how did you partner, or what kind of messaging did you use to help create this cross-sectional messaging that you were talking to us about?
From the Nigerian perspective, I think we learned lessons from previous instances and incidents that happened, especially issue of hesitancy regarding vaccination generally. But in most cases, when the campaign started from top, either from government or from any NGO that is so foreign to their society, it creates a lot of suspicious mind. The role of religious leaders, both from the Christian side and the Muslim side, became so significant in whatever campaign you want to launch in the community. It's an issue of trust. No matter how you try to let people understand the need for vaccine, if they have no trust in the people doing the campaign, you hardly penetrate them and you hardly deliver. So the religious leaders have this reputation and respect, and they command trust in the heart of many Nigerians. So the collaboration between the health providers and the religious leaders is helping a lot to launch the campaign. The other side of it is engaging the local health workers in each community to start the campaign. It shouldn't start from a stranger in the society. These people living in their communities, they have trust in the health providers, no matter how little they have in terms of knowledge, but they go to them, they refer to them on their daily needs for malaria, for other necessary things. So when these people collaborated with other partners in creating awareness, they quickly get accepted in the society. But when you have someone that is so strange in the society bringing the campaign, it's always suspicious. So the collaboration between the religious leaders and the health providers helps a lot to create awareness. And using the local health providers and the local communities to initiate the campaign, to initiate the awareness. Let these people believe that this thing is real and it's something that can be prevented.
Well, gosh, we're hearing such a common theme of how important communication is and messaging and trust. So, Bernice, in your research, what about communication strategies have we learned that we should continue to use, and maybe what strategies should we leave behind? Are there any general issues here that you can address or talk to us about?
Yeah, so that's a great question, Linda. I think that I focus more on listening than communication strategies. I mean, partly that's my training. I'm not a trained sort of public health worker or physician, but what I find is that we jump to conclusions about what people are worried about. And Noreen was really interesting, sort of commented on the need to debunk things that are going through social media, but it pays to pay attention to the specific things that are actually being raised, because parents have different kinds of concerns. And a lot of times parents just want their concerns to be taken seriously, and they want to be listened to, and they need specific information, not general information. So in the climate of vaccination controversy, there's a lot of discourse that when people raise concerns about vaccines, that they're somehow anti-vax, that they're against science, they're against the public health. People have actually specific concerns about specific vaccines. And those specific concerns need to be addressed. In order to address the specific concerns, you actually have to listen to what people are concerned about. And you may have to listen more than once. I think that's the logistical difficulty that Noreen was really pointing to in resource poor contexts or areas where there's a lot of climate instability and things like that. It's hard to get people to come back to the clinic, but they may actually need more than one conversation about a vaccine. There might need to be multiple conversations over years before people are comfortable giving certain kinds of vaccines. And especially for a vaccine that's sort of like a silent killer, right? You don't see the effects until much later. It's not like measles or polio where you know that you are preventing a disease that is going to come through your country in sort of like these waves of epidemic infection. And so I think that really sort of listening is the start of a good communication strategy.
Noreen, I know as a medical provider, sometimes, we're hearing about the importance of answering questions and discussions, but sometimes it seems like we have, constraints on our time. Have you had any way of spreading the message that isn't involving you personally, like using people in your clinic or task shifting or so forth, or any examples of what can be helpful for for having that opportunity for parents and girls to ask their questions in a way that doesn't feel rushed to them.
In the clinics, obviously, we have this time constraint, and, you have to answer all the questions, which can sometimes be a very daunting job, because sometimes, people ask one question and then another 25 questions after that. Some of them are unrelated as well. But I think when we are doing something out in the community and we are personally so convinced that the vaccine works and it can save a life, and you just need to see one woman suffering from cervical cancer and you know the value of the vaccine. And for that to really spread out everywhere where we can't reach, obviously, I think it is very important that we take time and train our juniors, not only doctors, but also the mid level providers, the community health workers, the lady health workers, and also the female welfare workers, the people who relate to families, people who visit the families. Even if they do not give the vaccination, they can actually help us a lot. And to help them, not only teaching is enough, but we also need to continue with what we call supportive supervision. That there are like groups, there are lady health supervisor groups, and then they have the liberty to text me or other people in my team if they have a question or a query that they did not know. That is a continuous effort that you have to make. And another thing that really helps is talking to people in groups. If there's a parent teacher meeting in a school and you get the opportunity to go talk to like 300, 400 parents, that's a wonderful opportunity. Likewise, in the community, when they have their health fairs, or we get the local influentials on board, MPs, counselors, so they can have a big gathering of not only women but also men in their respective areas. If we want to target the younger generation, of whom we have like 65% in our population, there is nothing that will work without very solid and continual social media presence of the materials, whether it's a talk or a webinar or a pre-recorded message that can help address their questions and queries. And likewise, like Bernice was saying very rightly, social behavioral communication, change communication, it is extremely important. Talk to the people in a way which is understandable to them. And if you allow me, I just wanted to take up on the religious side of things that Bernice was saying. That is also so true. Most of our problems are socio-cultural. The government and the EPI, and we all used a little picture of the vaccine and the girl, and with the certification of being halal, because that is also one of the concerns. Because generally people wanted to know that the source or the composition of the vaccine is nothing against the religion. So that is one thing that really helped us.
Rashid, when you were working with across your sectors with the religious and the community leaders, what was the actual education that got the local people on board, that got the religious leaders and the community health workers believing that this indeed was a good vaccine?
The community and the society at large, this hesitancy of what could have been the possible reason for this vaccine, the most important thing is to educate them properly, especially from the side of the health providers and the trusted ones. If we come together during when we embark on this campaign with a colleague, Professor Manga, Professor Muhammad, who happens to be a professor of medicine, and I, as an imam, we discussed together, we understand one another. The first thing we did was to organize a focus group discussion with religious leaders so that they will have adequate understanding about the whole thing. It generated a lot of debate, it generated a lot of disagreements, but at the end of the day, we were able to agree and understand. So we discovered that there are a lot of elements of ignorance about the whole vaccine. If the religious leaders, who are the opinion leaders of the society, did not get it right, automatically it will be very difficult for the society to get it right. Some of the success stories was that one of the imams that we were together said he has about is it 7 children. He has never subjected any of them to vaccination because he didn't believe in it. And that's why when we were selecting the imams, we were so keen not to select those that actually support vaccine. We want those that didn't support the vaccine earlier. So when we brought them together, it was a hot debate, and almost everyone was convinced that yes, this thing is real because he had it from authorities in that field.
Yeah, I think certainly having seen stigma greatly in this disease and any below the belt cancer, actually, or any below the belt issue, I mean, I feel like the power of people's stories too, to bring forward, survivors of cervical cancer or head and neck cancer. And like, this is really something we want to avoid. And so trying to get those stories out there, wrapping it with information about how we can avoid it, I feel is one way to stigma bust. And another is to just keep trying to talk about it. We have the power to really change people's health with this tool.
Yeah, when we talk about the stigma, and in my part of the world and many other parts as well, anything that has got anything to do with girls and women's reproductive profile or career or health is a stigma. Talking about periods is a stigma, period pain is a stigma, pain at the time of relationship is a stigma, even urinary incontinence after birth, everything along the whole life cycle is considered to be a taboo subject, and people don't want to talk about it. So this is why I was alluding to the fact that if we don't tell our masses and men and women that cervical cancer exists, that head and neck cancers exist, that oropharyngeal cancers exist, and we just land this news with a vaccine which is so costly and suddenly the government has got it free, I think the public is genuinely freaked out. Why? And why my daughter? And then when it is not being offered on a gender neutral thing, they think, well, it is something which is going to mess up her reproductive career. So I think all this homework and the layering up before we actually come to the vaccine is really, really important. And we have to remember that these people are not medically qualified. Even the OBGYNs have doubts about the vaccine. I'm sure you've experienced that in the States as well. There is a group of very senior people who just think, why are we even talking about it? There's not enough cervical cancer in the country. Whereas we lose 9 women to this disease every single day, round the clock, 365 days a year.
One of the things that my research really has taught me is that the thing that is said is not always the thing that's at stake. And I think that what's at stake here is so bound up and confused with women's roles and changing roles in society. I was working with a student here on a project. He's a Mennonite student, and he was interviewing Mennonite families about their attitudes towards childhood vaccines. And HPV came up quite a bit. And one parent said something I will never forget in one of the interviews. It was a father, and he said that to give his daughter the HPV vaccine would be like saying that he didn't trust her and her choices later in life, and that he just felt like that was it was a terrible thing to do, to not trust his daughter. And that really affected me. I'd never thought about that before, about how bound up parents' views about raising their children in certain ways with certain values. And we know that that's not the way the virus works, right? But that's not the effective response of this father. The effective response would be that if I allowed her to be vaccinated, I would be communicating to her that I didn't trust her future choices. And I think that, to me, that just puts the whole question in a very different space, where what you have to communicate and how you have to listen are really different than what we maybe expect about a childhood vaccine.
That is a very, very common thing, even amongst very senior OBGYNs. If they find a woman with cervical cancer, they immediately are wary of the partner and his faithfulness and his reproductive profile. And they would say stuff that should not be said. So people just think that bracketed good married people don't have HPV. Everyone believes that HPV is a disease of infidelity or wrongdoings, and people who are good will never get it. And And that's one of the basic reasons, along with the STI version, which makes it very difficult to talk about it in a disease neutral fashion, I think.
Well, this has been a wonderful discussion, and I've learned a lot from each of you. So I really appreciate the opportunity. I think as we close, would you have an opportunity also to share, is there anything special that you would like to impart as we wrap up? And, I guess for me, I think one of the things that I really decided was important was that I wanted to document people's stories with this disease, and then behind their stories in everyday language, explain how we could prevent it, how we could actually end this cancer, and why aren't we? What can we do better? And one of the things that I ended up doing was writing this book called Enough Because We Can Stop Cervical Cancer. And it is a testimony to women around the world from 6 continents with cervical cancer with information behind it.
So I also wrote a book, Anti-Vax. This book was published before COVID. So it was published in April of 2019. The COVID pandemic has changed attitudes around vaccination, in part because of resistance to public health efforts to contain that pandemic. But I think most of the points that I make in the book are still valuable. And one of the main things that I try to do is show how concerns about vaccines are linked to other concerns across the culture, and especially to concerns that governments don't care about people and are willing to sacrifice people for the greater good. And that what that means then is this erosion of trust that all of us have talked about and experienced.
Rashid, any last thoughts you want to leave us with?
I'd like to emphasize the point that once we understand that this campaign should be a multidisciplinary one, then we are very good to go. So there are a lot of disciplines that will come together to help us mount the campaign. And we should never underrate the influence of the media, being it a social media or the mainstream media. A lot of means of campaign should be used to educate and enlighten, starting from the elites. It will go down to the common man in every society.
And also for you, Noreen, any last thoughts?
I'm really proud to share the space with all of you. Your work is fantastic. And I just think that we have to be respectful of the views of the women and the families, because they are the reason that we are here. And for the campaigns, I think we need to do our homework really, really well. And one thing that can certainly help is that if we talk about cervical cancer or head and neck cancers and then bring in the vaccination, that is the logical sequence of events.
Thank you so much for listening. All of the resources that we've mentioned in this podcast are going to be available. If this discussion is something that you would like to share or it inspired you to share information, the International HPV Awareness Day campaign website has a wide variety of experts, of survivors, of public health information in 10 global languages, actually. It's a wonderful resource. And so you can find a suite of really inspiring lived experience videos from people who've been affected by HPV cancers across the world. Visit www.askabouthpv.org and start a life-saving conversation today with your community. Thank you so much.